Hello and welcome to another episode of Out of the FHIR podcast, where we discuss all things FHIR interoperability, data, AI, analytics, provider data, and other things. So today we actually have Ron on the show talking about the last topic, which is provider data. But Ron, feel free to go into any area that you want to discuss, from FHIR to regulations to anything else, honestly. I think, first of all, I know, Ron, we have a little bit of interesting connection through Pittsburgh. Ron, you went to school at CMU, I believe, in Pittsburgh. And obviously, I'm in Pittsburgh, and I went to school for my graduate degree at the University of Pittsburgh. So it's always nice to meet an Pittsburgh kind of local and discuss all of the cool things about Pittsburgh, which we may have another episode to discuss that separately. But yeah, Ron, why don't you introduce yourself?
Well, let me mention something about Pittsburgh real quick, and I'll be brief. I lived in an apartment building my freshman year of college. That was the same apartment building where Mr. Rogers had an apartment next to the
my
studio.
God.
So I hadn't seen him in the apartment, but a couple of my classmates saw him walking around on their way to class. So just a fun little story. In terms of myself, I've been in health tech ever since the mid 2000s. Started off in software development roles and in product management roles. I jumped into the payer space in the 2010, first focusing on kind of risk adjustment and HEDIS quality solutions, clinical data capture. Moved to CAQH, and that's where I met my co-founder, DJ Theogarage, and we worked collectively between the two of us on provider data and interoperability and credentialing. So that's where we got to really understand all of the nuances of all of the provider data problems, both on the payer side and on the provider side. Then we launched Defacto Health in 2021, and our entire focus has been integrating with payers, provider directory APIs, and other public provider data sets resemble the largest data set of healthcare providers and the insurances they accept. And the data is being used for a multitude of different use cases. We can go into details around those. But, and maybe this is a jumping off point, but the kind of triggering activity or the genesis event was the 2021 effective date of the CMS final rule on patient access and interoperability, which required that the payers make available their provider directory APIs. So that's kind of sparked all these different uses of the data and transparency into the data, and hopefully it's going to be a catalyst for long-term change in the industry.
Yeah, that's interesting. So you kind of saw it. If you were kind of like so in tune to the regulations that you saw it coming, and then you actually acted on when you saw the regulation being passed, which is pretty amazing. I don't know many people. First of all, most people don't know what regulations are even passed out there, right? And then to actually act on it is like a really amazing level of foresight.
Yeah, we honestly didn't know if it was going to work, if the data was going to be there or not, and we just started taking a look at these APIs. I remember the first API we queried was United Healthcare's provider directory API, and we just started seeing all the data flowing, and that we could logically associate healthcare providers with the insurances they accept. We mistakenly thought that everybody's API was going to be as good as United Healthcare's API, which was very much not the case. After we integrated with United and with Humana's, it kind of fell off from there. I mean, there were missing data, there were completely empty APIs, there were non-conformant APIs, there were non-existent APIs. And so that has been probably the majority of our work for the past 4 years has been, okay, let's just go down the list of payers. Do they have an API? Okay, good. Does the API work? Okay, is the data in there? Okay, can we get to all the data? And, so we did that hundreds of times, and you have to revisit them on a pretty regular basis. So, we thought FHIR standards-based APIs should be pretty easy, write once, run everywhere. That is unfortunately not the case. It required a little bit of custom integration and working through all the nuances, which I think some of your previous guests on Other episodes have shared similar experiences with their patient access API integrations as well.
Yeah, absolutely. A couple of questions I have on that and your perspective, but like the main one is, do you feel like most payers overall, and we've heard this term, checkbox compliance, right? So like when I think about these payer, provider, provider directories, do payers not think that it's, it's like an opportunity to drive their business, or do you think that mostly they just look at it as this kind of checkbox compliance?
I feel like for the past few years, ever since the effective date, it's really been let's check the box. And the reason I'm not in the room when they're having those discussions, but I do see the RFIs and RFPs that they send out about, hey, we're looking for a vendor mate to make these APIs available. And it's all about compliance. They name the regs, they name the requirements, they name the specific requirements that the regs mention, and they don't go into much more detail about the use cases it's supposed to support relative to patients or their members who are trying to get access to the data. Maybe they give a little bit of description of that, but it's mostly around, does this support the regulation? I am seeing a little bit of change over the past year, though, especially among some of the top payers. They're looking at APIs, but also just machine readable data in other public data sets and their websites as an opportunity to market, because it used to be that they could just use a bunch of brokers and they could put some nice marketing material on their website, and that's how they're going to sign up members. They've got their sales team that go to the employers, et cetera. We're living in an AI agent, chatbot type of environment now, where you actually have to market to bots. You have to market to AI agents, and in fact, many of the new innovative brokers or solutions vendors for brokers, they're AI first type of platforms where they're bringing in a bunch of data, perhaps from folks like me, but also from others, also from the payers' websites, and bringing that into their engine that helps make recommendations to members, individuals, and employers. So I think payers, some of them are viewing this as an opportunity to get more data out there to help people make better decisions. But it's probably still in the minority.
Yeah. That's fascinating to me because I feel like it is almost like a chance for you to participate in this new ecosystem of connected healthcare and enabled, AI enabled care, where you get to influence that by making your data available, and then not even talking about the accuracy of that data, right? Like not talking about the usability of that data, or how up to date it is, which is like which is a weird thing that we just haven't figured out how to keep data up to date. It's like it's kind of like reminds me in my house, like watering the plants or putting things on the refrigerator, for your kids. And like make your bed every morning, close the door so the dogs don't go in there, open the window, like do all these little things that like, hey, every day you do it just out of like basic hygiene and whatever. Like, why don't payers have processes that would make this data as up to date as it can be and as accurate as it can be?
I think there are a lot of reasons. Let's go through a few of them, and we can spend time on some if you'd like to go a little bit deeper. Let's quickly talk about the regulatory aspect of it. So there are requirements, and they vary from state to state. They vary from line of business to line of business, Medicare versus Medicaid versus commercial. There's the No Surprises Act on the commercial side, Medicare Advantage. CMS has done these secret shopper phone audits. There's also network adequacy requirements, which are kind of adjacent to provider directory requirements. In terms of provider, there are all sorts of requirements on how up to date the information needs to be. The kind of the lowest common denominator across the country is that these data need to be updated within web directories, but also APIs on some monthly basis. It's more strict and more frequent in some places. I mentioned the secret shopper audit, where you've got agents picking up the phone, seeing if, Dr. Gene is actually at 123 Main Street, and if this is actually his phone number. Can I actually make an appointment with Dr. Jean. So a lot of this constructive feedback is being provided to payers, but only in a handful of cases have they been held accountable for it. There's been some regulatory enforcement at the state level with penalties. There have been some lawsuits between kind of consumer or individual plaintiffs versus the payers, but largely, payers haven't been held accountable for provider directory errors. And I believe a part of that is that there's this assumption for the folks in industry who've been working in this space for a long time that perhaps this is an unsolvable problem because the average payer's accuracy has remained about the same over the past 7 years. Ever since CMS started doing these secret shopper audits, it's been about 50% accuracy. So, if you take any given record within a provider directory from a payer, it's about half and half likelihood that the data is accurate or not. So I think that has maybe made regulators reluctant to enforce because they're not sure if there's actually a way for payers to get it right, because the payers are largely dependent on providers submitting the right information, and also the providers are not being held accountable for it. So I think it's some lack of enforcement and accountability, a belief that maybe the solution doesn't exist or these goals are not achievable, and that the providers are not being held accountable, and are they ever going to be able to provide the right information? Now, what I'll say real quickly is that I do think that there are some payers who are doing it correctly in some markets. I've seen accuracy as high as 70% in some places. So some payers are doing something right. I'm trying to figure out what they're doing right. I've got some ideas and hypotheses, but I haven't, I've outreached to a couple of them to ask them, hey, what's your secret sauce? And they've been kind of silent on it, but I'm awfully curious about how the good ones are getting it right.
Yeah. Yeah. And it's amazing, like, if there's some of these good ones out there that they haven't tried to capitalize on it. Like, they haven't tried to, like, take that secret sauce and, like, hey, guys, we're going to spin off this, because that happens with healthcare all the time, right? Like, big health systems and big payers, they have, like, oh, wow, this can make us a lot of money. Let's do this. Like, it's amazing to me that hasn't really happened in the provider space.
I have seen some payers who have made investments in these provider data companies, and they've spun them off, or they still hold some type of stake in them. Surprisingly, those are the same payers who have very high accuracy in their directories. Yeah. So I think there's still some relationship there. So I think there's some of that going on. I think payers are reluctant to market, amazing 70% accuracy because, for a layperson, that sounds awful. It's like, wow, 30% of your directory is still inaccurate. It's like, well, but everybody else's is a whole lot worse. But that's not going to get you that far. I have seen cases where in a state bid for payer business, like a big state government employer, for example, there will be one payer is bidding against another payer, call into question payer B's provider directory accuracy to throw a little bit of fear, uncertainty, and doubt around the quality of their bid. So, there's a little bit of that going on from a competitive standpoint, but it's not widespread.
Yeah, and I would be interested to see, like, if you break down those numbers, it's like a specific specialty that's more at fault than, like, just generally providers. Or, like, I would, like, suspect that, like, certain specialties have their stuff pretty well together and others are just not. Yeah, that would be an interesting level of analysis. I don't know if that's something you've looked at.
It has been. The one type of provider that I've historically seen being pretty bad are dentists, so dental providers. I'm very curious why. I think part of it is that dental plans have not been held accountable for their provider directory accuracy. There hasn't been a lot of regulatory scrutiny on them. But also, I think probably people are able to look up their favorite dental practice and find the right information pretty easily. So maybe it's just not a problem. But I've assessed the accuracy of the dental provider directories, and they've been pretty bad. I mean, others are types of providers hospital-based providers, that happens a lot because these large health systems, sometimes there's this behavior where they're submitting their rosters to payers and they just associate every single provider with every single location. And so that there's just kind of exponential opportunity for bad data because you're associating everything with everything else. And then there are some providers that are historically more virtual than others, or just don't see patients in person, and so that information is not as accurate, but also a lot of patients aren't looking to make appointments with those types of providers, like anesthesiologists and diagnostic radiologists. So it's probably not as big of a problem because patients aren't necessarily looking for them.
Yeah, and that's what I think, like, we'll never get to that 100% accuracy, right? It's just not feasible. But you can get to maybe like an 80% accuracy on providers that are actively accepting new patients and that are practicing, at least at one location. I don't know. I'm thinking about this recent conversation we had with you know, Josh Kelly, and then Brendan Keeler and Jason Colatanga, Fast and Health. We're talking about this whole concept of plaid, in healthcare. So plaid is like this kind of like network of networks and aggregator in finance, which allows you to find your banks. It allows you to find your accounts, your credit card accounts, blah, blah, blah. And it allows you to connect to them using your information. And it kind of provides that service layer. Do we need an equivalent of that? And obviously we had a whole conversation about that in some ways healthcare is well ahead in regulations. I'm not sure about the actual implementation yet, but in regulations, it's well ahead of the finance industry on the patient access APIs and the payer provider directories. But like, do we need that service layer enablement of somebody like Fast and Health also providing, or Defacto Health, providing that service of, we have all the information about all of the different payer directories and provider directories that where you can connect and find the organizations, the providers together, so you can enable the developers to easily do that without everybody needing to connect, pull down, and store 500 payer directories, which I'm assuming most most companies will not be able to do successfully, right? And you wouldn't even want that, right? Like, even if they could, like, why would you want to make 500 copies of stuff that you can just connect to one place and get them, right? What is it?
There's a question of, for specific use cases like provider search, provider appointment scheduling, plan comparison, or like Jason and Brendan and Josh probably cared pretty deeply about, find me the right API for me as a patient based on the care that I have or the payers that I'm subscribed to. I think there's a question of universality. Do you want to be able to search across all providers? Do you want to be able to search across all plans? Do you want to eventually find any provider who accepts my plan with available appointments with the right address? Do you want to be able to search across all payers and all providers, like this record location case, who may have data about me that I need access to, so I can assemble my personal health record and see longitudinally, how I've been doing, and share that information with caregivers and other providers. If you value that ubiquity or universality, then you need one place to be able to put it. You can't just, it's like going shopping. Do you have anything about me? Do you have anything about this provider? No. Okay, let me go to the next one. Let me go to and that would require you to have integrations with hundreds of different endpoints, perhaps thousands of different endpoints. And it's entirely inefficient to be able to ping each one and ask. So you kind of need a place to be able to, now you don't need a place for all the clinical information by any means, but you need metadata. You need at least a directory data, which is important metadata, and you need information about the provider. You may need to have some metadata about the patient to be able to enable record location, which it seems like that's the model that's being advocated for and discussed in industry these days.
Yeah, and like, to really enable that, it would be problematic right now, right? Because even if you talk about the patient access APIs, you may get some information on your providers that you have seen, right, that are associated, but that's not really connected to the payer directory data at all. So you might not even be able to associate the two on, hey, this is this particular provider, and here's all the plans that they accept and all the others. So basically, just like you think about this like universal provider record, there's no such thing that exists, right? It's all about based on the use case and from the level of quality of data I've seen just from the source Epic EMRs, patient access APIs, even though they're supposed to be US CDI, like version 3, right? The level of provider data that's sprinkled in all over like the electronic health record that a patient has is all over the place, right? So sometimes you may get the provider, sometimes you may not even get the right provider. You may get their, PA. You might get their just somebody was in the room and they documented them. So it's very hard to tell who the actual provider is. Is that a big problem to be able to associate to get this value out for the patient?
Yeah, I think there's two aspects to what you just described. I think one is kind of the quality and the completeness of the data. Is it even right, and is it populated in the field? I think the other aspect that I'm a huge champion for is these join keys. So, how do you identify a provider, a provider organization, a plan, a network? And it crosses different data sets and different use cases. And if you combine data sets together, then they become more valuable. I think that's something that data folks quickly realize as they've spent any time in industry. So, I was at a work group meeting with a bunch of price transparency vendors over the past week, and we were talking about the same topics as we were in some of the national directory breakouts at the CMS ASTP RFI meeting, where we need universal identifiers for networks, for carriers, and you need to have those same join keys within patient access API, within the transparency and coverage machine readable files, within provider directory APIs, because if you combine those three data sets together, you can really enable very interesting, healthcare shopping use cases and, comparison use cases. So yeah, we need those network identifiers, plan identifiers, we need TINs, we need NPIs available whenever possible.
Yeah. Where do you think that lives? And ultimately think about like the ideal future, like AI enabled, you have model context protocol so that you can easily have, LLMs, you have full transparency in the APIs so that they can use the model context protocol to query the APIs. Simplify, which I think simplifies a lot the act of you don't need a, software developer to create a pipeline manually to every payer. You just have LLM do it, right? And then agent to agent, I think, is the other one where you can have these multiple agents. So you can have an agent that kind of gathers the data. You have another agent that kind of is like enriching the data. And then you have another agent that is curating the data and then publishing the data to different sources or notifying patients, notifying vendors, companies that like new data has become available. How far away are we from that? And do you feel like there's as part of the CMS RFI that you brought up, like there's a real, I would say, urgency to it now that we can do this. We have the technology, we have the brains, we have the smart people in the room to like, yes, we can gather all the data and, tremendously improve the quality of that data and make it usable for all these use cases that we need that data desperately for, right? Like we understand that clinical data on its own just doesn't have as much value, specifically for the patient. I think if it's not connected to them being able to schedule their appointments, it's not connected to them being able to find the providers that they need, things like that. So what do you think is that
I think we're getting
solution?
close. Especially for the AI companies and the search engine companies. They're thinking about things on kind of a vertical by vertical basis and what use cases they can support. So Google has their annual, I think they call it the Google checkup, where they talk about, different things that they're releasing every year. And so if you remember, several years back, they started in select markets, including insurance plan information. So insurances that providers accept. I don't know if you can still see that in any of the searches. Probably in some of the Google My Business profiles, you'll see some of that information. But I think also in some select markets, they were enabling a direct appointment scheduling, through the search engine as well. And so you can imagine a world where this data becomes more available, both from providers and from payers in a more machine readable way to these AI agents or to these search engines, so that when you're searching for a dentist near me or a cardiologist near me, if probably the search engine already has an idea of what insurances you've accepted because you've Googled your own insurance company or you've logged in. So they can probably connect the dots and find, providers who accept your insurance. And, there are emergent standards around appointment scheduling APIs, which are not widely implemented, but there's some Argonaut IGs on appointment scheduling that, EHR has implemented, and hopefully a few more will over time. But as those become available, those will be available not only to third-party apps being used by humans, but also by agents. I think we're a few years away from that type of interaction being implemented in pockets, and it'll scale from there.
Yeah. And I think that's really interesting to see, because we obviously we know it's not going to happen all at once, but once you start seeing those use cases, and it's interesting. I don't know if you saw that story about Epic and Humana. They now integrate Humana, your deductibles and all your insurance data in Epic, which is, to me, it's a very interesting play, connecting that world, right? And I know Epic is trying to build its payer platform customer base and position that product. But it's interesting that Humana had enough value to get out of it that they decided to participate. What do you think about that? And also how it relates to like marrying the provider directory data and stuff with, EMRs and stuff like that.
I saw the headline. I didn't read past the first paragraph, but you can imagine trying to do this off the cuff, some use cases that would be possible once you bring in the payer data and marry it up with the data that is actually in Epic. On the one hand, I'm imagining Humana through that arrangement probably has some access to the payer platform to be able to get clinical data they need to be able to participate in the government programs that they have. So that's probably good for Humana to be able to do that. But also on the member side, they're able to make better decisions about care relative to their deductible and the upcoming appointments that they have, and doing care searches and providers who accept their insurance. Bringing data together from other places, because Humana does have, as a payer, they've probably got a global view on, all the different care in different contexts, in different institutions that member or patient has encountered, and being able to get the right data from all of those places into a single place to view. So it's a win-win actually for Humana as a payer and for the individual to be able to see all of that all in one place.
Yeah. And like my thought about that is like, also it's great that Epic and Humana are talking and are integrating their data, which is like, that is the answer to a lot of the problems, at least from an interoperability and outcomes perspective, is that lack of data. So now you have to enable that sharing. But how do we enable that at scale so that it's not just Epic and Humana, but it's everyone and United Health and like all these other, everybody has the justification and the need to do that from a bit both the business perspective, but also looking out for the patient. Is essentially like the regulations we have now like enough to do that? I know CMS has put out this national provider directory as a need. And are you able to speak to like what you have heard about that and what it's actually going to come of that? Are we talking about like something they're actually working on? Is it going to be a vendor they just, here, you guys go build it? Or is it multiple, just put an RFI out there? How's that going to work? And I don't know if you have any updates on that.
I think you're right that hopefully Humana and Epic aren't just building some custom integration. Hopefully they're actually using standards-based endpoints to enable this use case, which would provide all of us more optimism that this can scale across any payer and any EHR for any provider. What the regulations on the books right now, they mandate APIs to be made available across these different healthcare organizations. But, I think the discovery aspect of it is lacking. Like, it's hard to find an endpoint for a payer or for a provider. It's hard to get access to those things. Will a national directory help with that? Yeah, it'll help with that. And that's one of the first use cases that CMS and the Doge team are looking at. That's what I heard in the meeting in DC about a month ago. They want to be able to have a directory not of just provider information, but of their endpoints, and also payer information and payers' endpoints, so that all these organizations can discover each other and connect with each other. But I think you need to have more than just names and NPIs and plan IDs and endpoints. Eventually you'll need to have metadata about individuals as well, so that you can enable patient matching and find out where information about a patient lives. And there's privacy concerns and risks around that you have to manage. But that will eventually be something that needs to be addressed so that you can really have something that's ubiquitous and comprehensive.
Have you heard anything on how that's gonna, like, who's gonna build this directory? Is there any?
I don't know. I do know that CMS is on a hiring spree right now. There was a post about, that they're looking for a lot of engineers. So, perhaps it's something that's going to be maybe a combination built in-house and, outsourced.
Yeah.
But I don't know for sure.
And is that going to use the National Provider Directory Implementation Guide and the whole the effort on the HL7 side that was already in progress for quite a while, I think, right? So is that just going to be kind of built on top, or are they thinking about it's going to be something different?
I know there's an active conversation going on between the FAST group that is moving that IG forward and the folks actually doing the implementing. Both there's an Oklahoma pilot for National Directory that actually it just publicly launched, I think, a week ago. So now providers can log into that and submit their information to Oklahoma health plans that are on the marketplace. But also there's this new National Directory effort that seems to be a little bit more digital endpoint focused. At least that's out to that.
Yeah, because endpoint was, even if you go back to the Da Vinci PDEX and all the other employment, like endpoint was always there. It was not required and it was never populated. So it's like we always knew we needed endpoints. We just didn't want to make it a requirement, which now we realize it is a requirement. So that's very interesting. And I'm going to check out that Oklahoma pilot for sure and see how that's going. Maybe we have like part 2 on this, where we maybe a month or 2 from now, we just like talk about how things are going and any other takeaways, that we can put out there for the community. Kind of like the goal of this podcast to make like suggestions so that people can like, oh yeah, that's a good idea maybe that we haven't thought of, but also like just, learn from the past as well. So, and yeah, really appreciate it, Ron. So do you want to, any other parting words you want to just kind of like put out there on Defacto, anything, any interesting things coming up with Defacto that people should look out for, or anything else you want to add before we wrap this up?
We've got a lot of resources on our website for those folks who are interested in provider data and interoperability. We spend our weekends and evenings reviewing RFI comments and trying to synthesize them. So if that's something that you're interested in and you want a more condensed, digestible version of those things, feel free to visit our website. Hopefully it'll be valuable for you guys.
That's awesome. And thank you, Ron. I think Defacto has done a huge service to the industry in general. Myself, having worked with provider data and just been able to learn so much information about the quality of the payer data out there, to all sorts of clear quality issues, and actually trying to do something about it, which is really commendable. So really cool. Thank you so much for jumping on. I really enjoyed this conversation and hope we can do it again.
I enjoyed it too. Yeah, looking forward to the next time.